Welcome back to Mayo Clinic Radio. I'm Ian Roth.
And I'm Tracy McCrae.
Most cases of colon cancer begin as small, non-cancerous or benign clumps of cells called polyps. Over time, some of these polyps become colon cancers. According to the Centers for Disease Control and Prevention, of cancers that affect both men and women, colorectal cancer is the second leading cause of cancer death in the U.S.
But it doesn't need to be that way. Colorectal cancer is also one of the most preventable cancers if people get recommended screening. March is Colorectal Cancer Awareness Month, and here to discuss colorectal cancer is gastroenterologist Dr. John Kisiel. Welcome back to the program. It's good to see you again, Dr. Kisiel.
Thanks for inviting me back. Happy to be here.
Good. I guess it's a pretty important deal if it gets its own month.
I think it's a pretty important deal every month, but we talk about it more in March to raise awareness of the disease and the need to prevent it.
What are the risk factors for colon cancer?
Well, unfortunately, a lot of the risk factors for colon cancer are not terribly specific. They include a lot of the things that your mom told you not to do, like eat too much fat, too much red meat. Smoking and drinking are both associated with colon cancer. But for the most part, the biggest risk factor we can identify would be just your own increase in age over time, something you can't change. Men are slightly more likely to get it than women. We can't change that. And rarely there are genetic conditions that can raise risk, and you can't change those either.
Do we have any idea at this point what causes colorectal cancer? Why do these polyps turn cancerous?
Well, we think that it has to do with small errors in the proofreading process. When cells divide, they have to copy their DNA each and every time. And cells in the colon, because they grow rapidly and have to turn over every few days, are constantly having to copy their DNA. And a 1 in a million error can add up if you're having to make new copies every few days.
That's what a polyp is, a mistake in the copying of those cells?
Yeah, we think that there is either a mistake in the copying process or damage that might be induced to the cell through some of those environmental exposures that we talked about over a person's lifetime that can cause the cells to then grow abnormally and turn into polyps and eventually cancer if not removed.
So what's the difference between the cancerous polyp and the plain polyp?
So the plain garden variety polyp are precancerous. So they do not invade more deeply into the wall of the colon. They're confined to its inner lining, and they can be very easily removed with a colonoscopy, for instance, if detected. The larger they get, and the longer they're allowed to sit there, the more likely they are to turn into cancer, which by definition grows from the mucous membrane lining of the colon deeper into the wall. That's when they become cancer, and that's when they become dangerous.
So on a long enough timescale, all polyps will eventually become cancers?
We think that process takes about 10 years. What's surprising to many people is that many polyps will not turn out to be cancer. If you have 5 or 6 polyps, most of those, maybe 5 out of every 6, will involute and go away. We know that from long-term radiographic follow-up studies of patients. But occasionally a polyp will go bad, and that's what we want to try to prevent with screening.
So it has come to my attention, and now that I've got a lot of friends that are starting to have colonoscopies, that there are some people that they make more polyps, their body is just more prone to do that than others. Is that a genetic thing then, or just person to person?
It probably is a genetic thing, although the number of specific genetic diseases that we can tie to people who make polyps at a greater rate or who make more polyps than others, very few of those have been identified. So as someone who participates in screening, once we identify a person with polyps, we want to figure out how many did they have, how many have they developed since their last screening exam of whatever kind they had, and try to figure out what level of risk those persons are at. But importantly, we should emphasize that even though we know about genetic factors, we know about environmental factors, we know about family history, the disease is common enough, even among people who lack a lot of those exposures, that we still really want to focus on screening the general population. And that makes colon cancer prevention one of only a handful of diseases that we treat that way. Screening the general population is done to prevent breast cancer, uterine cervix cancer, and colon cancer, and to a lesser extent, prostate.
You kind of mentioned before that men are a little more likely than women to have colorectal cancer. Are there certain other populations, certain races, or anybody else who's predisposed to be more likely to have colon cancer?
Yeah, that's a great question. So we know that there is some racial diversity, and there are many factors behind that. They may be genetic, they may be environmental, they may be socioeconomic. There's a population in the United States, Alaska natives, who actually have the world's highest incidence of colorectal cancer. More than twice as many will be diagnosed than patients in the white patients in the lower 48 states. There's also been a lot of attention paid to some of the poorer outcomes among African American patients in the United States. And there are several societies that actually encourage them to start getting screened at an earlier age, beginning at age 45, as opposed to age 50, when most of the rest of the general population should start.
You talked earlier about it's a good cancer to get caught early, I guess is the best way to put that. Nobody wants to get cancer, but if you're going to get it, you catch it early through screening, and that's your best option with the problem, correct?
Well, by that I mean that we don't want patients to develop symptoms of the disease. That is usually associated with advanced stage illness that's going to be more difficult to treat or potentially is not curable. Those types of symptoms would include unintentional weight loss, bleeding, abdominal pain, a change in stool habit, anemia. Those are usually signs we don't want to wait to see. We would ideally like to find high-risk polyps and curable stage cancers when they're not symptomatic and at a point when they can be removed either endoscopically or surgically.
That's what I wanted to ask about, was the symptoms then. There is symptoms of the cancer. Are there symptoms of polyps?
Polyps are usually asymptomatic. In people who have a huge polyp burden, they may be more likely to have diarrhea, but that's a fairly uncommon scenario. So again, hammering home the point that waiting for symptoms to develop or only getting screened if you have risk factors that you can identify is not consistent with the general practice recommendation.
Is that part of why colorectal cancer can be so deadly? Because if you don't catch it early through regular screening, it's almost too late at that point?
Well, that's what we want to prevent. So more advanced stage cancers will be the ones that have spread into lymph nodes. Those are the ones that require chemotherapy in addition to surgery. Cancers that have spread outside of the abdomen into, or outside of the colon into the lung or into the liver are also therefore much, much more difficult to treat. And that disease spread is something that we really don't want to see.
Let's talk about that, because that's when you get to the stages, when it starts to, let's go through the different stages.
Sure. So a stage 1 tumor is one that is small and confined to the wall of the colon. A stage 2 tumor is going to be slightly larger. Stage 3 is where it goes into lymph nodes. And again, that's kind of a critical distinction, because that degree of spread means that we have to not just remove the tumor, but we have to apply some degree of systemic therapy. That's therapy to the whole body to try to treat tumor cells that have escaped the local environment. And that usually means chemotherapy and sometimes radiation. And then stage 4 tumors, although there are surgical options for those, only a minority of those patients will have a durable cure, and many will require some form of ongoing chemotherapy in order to prolong life and survival and quality of life, but they may ultimately succumb to the disease.
We've been talking colon cancer during Colorectal Cancer Awareness Month with gastroenterologist Dr. John Kisiel. We're going to take a short break.
When we come back, myth or matter of fact, 1 in 3 U.S. adults isn't getting the recommended screening for colon cancer. Welcome back to Mayo Clinic Radio. I'm Ian Roth.
And I'm Tracy McRae.
We're talking about colorectal cancer with Dr. John Kisiel.
So Dr. Kisiel, myth or matter of fact, 1 in 3 U.S. adults isn't getting the recommended screening for colon cancer. Ooh, is that a myth or a fact?
Unfortunately, that is a fact. That 1 in 3 result was obtained when investigators sent surveys to patients to ask them if they were participating in colon cancer screening, and that could mean exposure to any test that could screen for colon cancer, even if it was not intended as a screening test. An example of that would be a test for blood in the stool or a colonoscopy for abdominal pain or diarrhea. That's different than going in with no symptoms and asking for a screening test, which is what we encourage. So when people have gone back and looked at the medical records of the people that responded in those surveys, the real answer is it's closer to only 1 in 2 who are complying with regular programmatic screening to prevent the disease.
So what are the recommendations for screening?
So most individuals in the United States right now are encouraged by several guidelines and preventative services task forces to begin screening at age 50 in the absence of symptoms. Those screening recommendations are altered if you have family history of colon cancer. I won't go into the details, but generally we would ask you to start around age 40 or potentially earlier. And as I mentioned earlier, African Americans are encouraged to start screening in the absence of symptoms at age 45. And that's been endorsed by primarily GI societies rather than national level preventative care service task forces.
Aside from those folks up in Alaska, who else should be screened at a younger age?
So patients who have inflammatory bowel disease, that would be Crohn's disease of the colon or ulcerative colitis, they typically start a surveillance program that's different from screening because they're in a high-risk category. They start surveillance about 10 years after the onset of the symptoms of their disease. There are also much rarer genetic conditions such as Lynch syndrome or FAP, Poitz-Jeghers, juvenile polyposis. There are dozens of them that we're identifying. Those patients all have customized surveillance recommendations based on their family history, and those differ for each of those diseases. Collectively, people with a strong genetic risk really only account for about 20% of the cases of colon cancer that we see. And people with a specific genetic disease that we've identified, now that's only about 5 or 10% of people that develop colon cancer.
I think the idea of a colonoscopy is inherently unappealing for most people. Are there other screening options for those who are putting off getting a colonoscopy?
Yeah, so there are multiple different testing options that have been endorsed at the national level. And I think the overarching mantra is that the best test is the one that gets done. At Mayo, we primarily offer colonoscopy, CT colonography, the multi-target stool DNA test, and fecal immunochemical testing. There are other centers that may offer some other ones like flexible sigmoidoscopy. There are some other tests that can be provided to patients if they're not able to complete one of those other exams for some reason. But those are the major backbones of screening.
It has been proven that the prep is the tough part when it comes to the colonoscopy. I'll just say that straight up. What is your tip that you have for patients? I started telling people, well, here's what I've learned. Don't eat a lot in those days going in. Just start leaning down your diet. And I hope that made a difference.
Well, that's exactly correct. So that we're supposed to do that anyway.
Right.
So one of the big things that we want to eliminate from our diet up to a week before the exam would be sources of dietary roughage. So all the good stuff that you're supposed to be eating all the time.
It's kind of fun.
The whole grains, the high fiber, those can stick around in the colon for a long time. As you get closer to the exam, within 2 or 3 days, you're probably going to want to approach a more liquid diet. So a liquid diet would be anything that you can see through. So black coffee counts, popsicles, Jell-O, tea, broth. We want to avoid things with red or orange food coloring, though. Mm-hmm. Okay. And then there are a variety of things you can do with the prep itself. So there are multiple generic and prescription prep products that are available. We generally think that splitting the dose of the prep, so taking some of it the night before the exam, about half of it, and then the other half the morning of the exam, actually results in a better clean out overall. Prep can be unpalatable. I have patients that say that it's better if you chill it and drink it through a straw. Some patients suck on a lemon. There are also over-the-counter prep cocktails that we can provide We have instructions, for instance, here at Mayo on a prep cocktail that can be made from over-the-counter ingredients like Miralax, Gatorade, and magnesium citrate. And many patients tell us that that's probably the most palatable option.
The big point is it's not a reason to not get your colonoscopy done.
Absolutely not.
Let's talk about research and the study that you're working on.
Yeah, so we're doing several studies in the colon cancer space. We talked earlier about guidelines, and an exciting but potentially controversial new guideline came from the American Cancer Society last year, who suggested that patients at average risk in the general population start screening at age 45. The recommendation is controversial because we don't have as much evidence around that recommendation yet as we would like. And most of the evidence that we have now is based on computer simulation. So we'd like more to work on from the real world clinical data. So we talked earlier about different screening tests. Our group has studied the stool DNA test extensively. And there is a clinical trial that is now enrolling nationally that would allow patients age 45 to 49 to get a free colonoscopy and a stool DNA test as part of that study. So there are advertisements for that available now on social media. So interested patients should keep their eyes open. We're hoping to start enrolling for that in days to weeks. So we're very excited about that.
So the goal of this research is not only to be able to do a better job of diagnosing or looking for predisposition. Is that right? I mean, what are we looking for in these clinical trials?
Well, one of the reasons that the new guideline has been issued is that while we have reduced cancer incidence and mortality in patients above the age of 50 through population-level screening, we're seeing kind of a disturbing trend where, there's a growing percentage of cases who are patients coming in under the age of 50. And we don't yet know how to prevent that phenomenon or dent that trend. It's still a rare enough problem that we're not sure if screening the whole population will prevent it. So that's why there's interest in changing the guidelines and why people are asking that question.
I keep thinking about the awareness part of it because, here on the show we do lots of different awareness months and weeks and things like that. Over the last few years, 10 years or so, have you noticed, at least it seems to me, that it used to be, well, you got the colonoscopy if you were at risk or you got to be a certain age. It seems to me now that people are a little bit more willing to hear this, that they need to go get a colonoscopy done. Am I imagining that?
Well, I think there's been substantially more awareness. So as I mentioned earlier, the American Cancer Society, they had a big initiative where they wanted to increase the rate of screening to 80% of the population by 2018. And unfortunately, all of the effort that they put in didn't hit that target. So, I think also where a lot of the awareness and the change in guidelines is coming is that while colonoscopy is the most commonly used screening test, it's not the only option. And so, we think that offering patients multiple options, having providers who can educate their patients about the different choices that they can make, and then coming together to a mutual decision is probably the best strategy.
We've been talking about colorectal cancer and colorectal cancer awareness for the month of March with Dr. John Kisiel, gastroenterologist at Mayo Clinic. Thanks for joining us, Dr. Kisiel.
You're very welcome.